Untangling Pandas and Pans is a podcast about two little-known medical disorders characterized by the sudden and dramatic onset of symptoms such as obsessions and compulsions, vocal or motor tics, and restricted eating behaviors, and a whole host of other symptoms following a strep or other bacterial or viral infection. I have the privilege of interviewing some of the top researchers and clinicians in this rapidly growing area, known by various names such as immune-mediated neuropsychiatric disorders, infection-associated neuroimmune disorders, and autoimmune encephalitis, or simply PANDAS and PANS. My name is Dr. Susan Manfull. I am a social psychologist, the executive director of the Alex Manfull Fund, and the mother of Alex Manfull, who died at 26 years old due to PANDAS, a disorder my husband and I knew next to nothing about, certainly not that our daughter could die from it.
This is Episode 3, Part 1 of Untangling Pandas and Pans, recorded May 13th, 2024.
May is Lyme Disease Awareness Month, so I am very happy to welcome Dr. Shannon Delaney to talk with me about Lyme disease, Borrelia burgdorferi, and other species of Borrelia, as well as other vector-borne diseases such as Bartonella. Dr. Delaney is an expert in tick-borne diseases, as well as PANDAS and PANS. And more broadly speaking, she is an expert in the role that infection and the immune system play in neuropsychiatric disorders, otherwise known as neuroimmune psychiatry or immunopsychiatry. After her residency, she pursued a 3-year research fellowship at Columbia University, where Dr. Fallon was her mentor. And then she joined the faculty doing both clinical and research work, specializing in children and young adults with complex neuropsychiatric disorders after suspected Lyme disease and other tick-borne diseases. She is currently in private practice in Manhattan. And when she's not in her office, I suspect you'll find her on the tennis court. Okay, let's get started. When we first met in New York a couple of years ago, I asked you how you got into this field that treating complex neuropsychiatric disorders, perhaps we might call it immunopsychiatry. And it seems that it was your residency that was really a pivotal experience in leading you into this area. So I know I always like to hear how someone got into the field that they're working in, and I think that our listeners would like to get a sense of that too.
Sure.
So can we start off with that?
Yeah, happy to start there. So I'm sure you've heard of the condition NMDA receptor antibody encephalitis.
Yes.
Right.
Made famous, I suppose, by Susanna Cahalan.
Yeah, exactly. Her book, Brain on Fire. So that condition was actually first discovered right around the time I was an intern. So this is like 2009. And so I was super fascinated because here we have an autoimmune condition where an antibody, first of all, there's some sort of infectious trigger, usually a virus, that creates an abnormal antibody that attacks the brain and gives patients neuropsychiatric symptoms. Most of these patients who have NMDA receptor antibody encephalitis usually first present with just psychiatric symptoms, and usually it's psychosis. And then typically the typical course is that they would then develop more serious symptoms, like more neurological symptoms, often end up in the ICU, that kind of thing. But intriguingly, they usually always present with psychosis. So here I was as an intern, psychiatry residency, just kind of starting out. And I was very interested to know that here we have this condition that presents with psychosis because there's really no other condition that we know of that has a very specific pathophysiology, and then it produces a psychiatric symptom. So I thought it was a really interesting way to learn more about sort of the nature of psychiatric symptoms from like a neurobiology level. And so I was really interested in that. And then that got me thinking about how many psychiatric patients for example, are in inpatient psychiatric units and they actually have some sort of medical cause that might be triggering or, contributing at the very least to their psychiatric symptoms. While that was happening, also I was in my adult psychiatry residency. And when you're working in residency, you often spend time working in the hospitals. And as a psychiatrist, you're on what's called the consultation liaison team, a CL team. And what happens, your role in that CL team is that, so these are patients who are hospitalized medically, and oftentimes they have psychiatric symptoms that develop during the course of their hospitalization or other like psychiatric or psychological things that they think it would be important for a psychiatrist to weigh in on. And so while we were serving that role, we would often get a lot of consults for patients who come in with really complicated medical situations and symptoms. They would get like the multi-million-dollar workup. Everything would come back negative. The doctors wouldn't know what to do with them next. And then they would call a psychiatry consult. So you can imagine how happy the patients and the families were when they find out that a psychiatrist is coming to their bedside when they're coming in for like left-sided pain or weakness or something like that. They're usually not that happy. So we would go and do these evaluations, and I found myself kind of always siding with the patient, if you will. And oftentimes the attending psychiatrist would come in and they would take a very psychoanalytical approach to what was going on, and they would do a psychiatric history, but then come to the conclusion that their current more medical symptoms were maybe related to something that had happened to them psychologically in the past. And it usually wasn't a trauma or anything very specifically linked to these symptoms. But I remember one case where they thought the patient had moved 7 years ago and that was contributing to their current symptoms, even though there was like no rational reason why that would have been the case. And the patient wasn't saying that. And so it just got me very frustrated with the field in general, because I did not think that that was a suitable answer and approach to treating this patient. So it wasn't just that kind of thing happened once. It would happen time and time and time again. And then I was thinking, well, maybe it's like a regional or a hospital institution affiliated kind of response to things. I wasn't sure, because you're in residency and this is kind of the first time that you're learning about all of this and experiencing new hospital systems. So then I moved to New York for my child psychiatry fellowship. And I basically noticed the same version of a similar thing, except now it's not adults that I was working with, but kids and their families. But I noticed kind of the same phenomenon going on, that there would be these patients presenting with complicated medical issues. Basically, the medical team wouldn't really know how to address them or what to do, and everything was coming back negative. And then they're sort of the only thing they could do in those moments is call psychiatry. So I saw that as a failure of the medical system to understand what's happening with these patients. And so that actually motivated me to go on to do my research fellowship at Columbia, because I was just frustrated, because at this point, this was now 3 years of residency and 2 years of fellowship, kind of encountering the same problem. So that's basically kind of the long version of how I got into this type of work. And then the reason that I chose a research fellowship, again, I was very interested that there might be a lot of patients in psychiatric units who have immune or infectious contributions to their illness. So at that point, for my research fellowship, you could kind of pick your project. So I recruited patients with psychosis, and I didn't even have a research assistant basically at the time, because it was a very low budget study. And so I ended up seeing over 100 participants with psychosis, and I evaluated them. I took blood samples from them. It was quite a big undertaking to do when you're the only one kind of doing the entire study. But it was motivated by the fact that NMDA receptor antibody encephalitis had just been discovered, and also the fact that I had just gone through these clinical experiences, and those were highly motivating to me as well.
So what were you looking for?
Yeah, so Yeah, at the time, I had a research collaboration with a neuroscientist in Germany, and they had like an immunopsychiatry company. So they were looking at a lot of these anti-neuronal antibodies. Again, there at this time there was kind of a whole panel that had been discovered over the last couple of decades. So these are known antibodies that can cause some of these neuropsychiatric syndromes. So I sent blood to him in Germany, and he looked at a lot of these anti-neuronal antibodies. I was looking at other inflammatory markers, just like general inflammatory markers like C-reactive protein. I was looking at vitamin D levels, things like that.
Hmm. Were you familiar with PANDAS and PANS at that point?
I was through my clinical work, but surprisingly, I hadn't really encountered a lot of, I mean, thinking back, obviously some of the patients in the CL service may have had that diagnosis. And so we were a little bit familiar, but it was not really something we actively talked about during our training, and we certainly didn't get lectures about it or anything like that.
Mhm.
It was still a pretty new concept.
So it sounds like you weren't, well, were you asking about infections that they had had prior to the onset of the psychosis?
So I think I asked them a little bit about their infectious history. At that time, you had to pick a research mentor. And so, how I got to Lyme disease is that the person who was most related to this topic that I was interested in, infectious and immune contributions to neuropsychiatric disease, was Dr. Brian Fallon.
Mm.
And he had kind of made his entire career studying neuropsychiatric aspects of Lyme disease. So that's how I got to Lyme disease, because he was my research mentor, and I would go to their lab meetings every week and I would learn a bit about Lyme disease. So it was kind of a circuitous kind of path. So I did ask a little bit about infections, but if I were to do that study again, like 10 years later, I would obviously like think about it differently based on everything that I've learned since then.
So do you feel like you're a detective sometimes? You've got these presenting symptoms.
Yeah, I would say that was sort of the medical detective piece of it is probably one of the most exciting and rewarding parts of the job, just because I firmly believe that establishing the correct diagnosis is really key to all of these symptoms. Because in order to properly treat things, you really have to try to get to the bottom as best as you can about what's triggering everything. So yeah, I get very excited about that part. And I still get excited when lab work comes back, gets faxed to me. Like even if it's late at night on a Saturday night, I want to see what the result is, because it can just help better inform us in terms of like the path going forward.
Hmm. So just to be clear, for you, diagnosis is extremely important, but also what the cause of the presenting symptoms are. Let's say that we see someone with obsessive compulsive disorder.
Mhm.
What's causing it? Do we look for medical causes? Do we ask if they've been sick recently?
It's a good question in terms of like, at what point in an evaluation do you sort of go more down the medical road versus like the purely psychiatric road, for example? Most of the time, and this is just sort of, I think, a bias of patients who are coming to me, usually they know enough about what I do, the fact that I am a specialist in treating Lyme disease and PANDAS, that the diagnosis piece, there's enough of a suspicion that the working diagnosis is like a PANDAS situation, that oftentimes it's not something that I'm coming up with on any sort of novel basis. They have enough of the symptoms that would clinically make them very suggestive of a PANDAS situation. On occasion, I'll see somebody and I'll hear their history and I'll like really spend the 2 hours with them, and they don't so much seem like a classic PANS or PANDAS case, because maybe when you actually get to talk to them more and you get more of the history, things came on sort of slowly. It wasn't this new onset change. It was more like let's say, depression during 5th and 6th grade, and now we're seeing more OCD, but it was never treated. So is that PANDAS? I don't know. I still do the infectious workup, but most of the time, the kids I'm seeing, there's pretty abrupt change of personality. And so there's not so much a question of whether or not that fits a PANS diagnosis.
All right, so we're here to talk about Lyme disease and other tick-borne illnesses and how they might relate to PANS. So can you just start off by telling us a little bit about Lyme disease?
Sure. So Lyme disease is caused by the bacteria Borrelia burgdorferi, and it was first discovered actually in the early 80s. And what we know about Lyme disease is that the bacteria itself, it can be only transmitted through a tick. So that's unlike some of the other infections, which we can maybe talk about a little bit later, such as Bartonella. But Lyme disease, for example, what we know of in terms of the science as of right now is that it can only be transmitted. Borrelia burgdorferi can be only transmitted through a tick. And what we also know is that Lyme disease has been found in every state now. We know it's highly concentrated in the Northeast, for example, and also the upper Midwest, such as Minnesota and Wisconsin. All of those areas are hot spots for tick-borne illness. And in terms of how many people are getting diagnosed and treated every year, honestly, that number is always changing. So prior to 2000, I think it was 15, the CDC thought that only 30,000 Americans had Lyme disease every year. And then they came out in 2015, I believe it was, and said, oh, actually, we think we made a mistake with one decimal point. It's not 30,000. It's actually 300,000 people who are diagnosed and treated every year. And more recently, they've come out and said, well, now the number is even higher. It's closer to 500,000. So the actual figure, I think, is somewhere around 476,000 Americans diagnosed and treated with Lyme disease every year.
Wow.
Honestly, that's probably an underestimate just because of how significantly it's changed just in the last less than 10 years.
What do you attribute that exponential growth of cases?
Well, some part of it probably is just under inaccurate reporting before. There's a lot of different thoughts and causes, like global warming, for example. Deforestation contributes to the spread of ticks. We basically know that ticks will be out if it's 45 degrees or warmer. So that basically means ticks can be outside all year round, even in the Northeast where it gets cold. Where I live, which is north of New York City, gets quite cold and snowy most of the winter, but we can have occasional warm days in the winter. And I've had neighbors come and say, hey, I was just it was a warm day that was 48 degrees and I was bringing in firewood and I got a tick. So you're never really safe from ticks. You should always be thinking about them anyway, if it's 45 degrees or warmer. So yeah, global warming, I'm sure, has played a role in that as well.
Hmm. And in Europe, what are we seeing? Are there some countries that are more affected than others?
It's a huge problem in Europe too. They have a slightly different type of Borrelia bacteria, so it's not Burgdorferi, but there's Borrelia guarini and Borrelia afzelii, but it's all over Europe as well. And honestly, if you thought, a lot of people have unfortunate experiences with the medical establishment in terms of finding doctors who are knowledgeable about Lyme disease and willing to treat them and understand the chronic nature of things. It's actually amazing in the US compared to Europe.
Oh, interesting. Now, we have quite a few listeners from Australia. So I looked up the stats there and read that it's claimed that Borrelia Burgdorfera is not present there. Is that your understanding as well?
I don't know that I have any like specific scientific thoughts about that. I do know I've encountered a lot of patients from Australia.
Mm-hmm.
Most patients travel the world and travel to different places all of the time. And I've seen numerous patients who sometimes get tick attachments or get sick after like an isolated experience somewhere on vacation for a couple of days.
So now there are other species of Borrelia. You mentioned a couple of them, and one of them that we talked about earlier, the Miyamoto,
Mhm.
as a species of Borrelia. Can you talk a little bit about that?
Sure. So yeah, Borrelia miyamotoi is also from the Borrelia family. It is actually a new tick-borne illness, and it's kind of like a cousin to Lyme disease. So when I explain it to people, there's the Lyme Borrelia family, and then there's something called the relapsing fever Borrelia family. And Borrelia miyamotoi falls under the relapsing fever Borrelia family. So when I first started on faculty at Columbia in 2017, I was hired to sort of evaluate kids and adults who are presenting with suspected tick-borne illness. So I was learning about a lot of these tick-borne illnesses for the first time. And I was super fascinated about Borrelia miyamotoi, primarily because I had never ever heard of it before as a physician. And I assumed that most doctors and most people had never heard of this before. But as I was working there and we started testing everyone, we were coming up with quite high numbers
Mm.
of people who were positive for the Borrelia miyamotoi antibody. And the reason why this was so important is because, again, this is a new tick-borne illness. The first cases in the Northeast, I think, were just discovered in 2013, just like super new and on the history of medicine perspective. And the other interesting thing about this disease is that it presents almost identically like Lyme disease. So basically, you have a group
Oh,
of people
interesting.
who are presenting with potentially cognitive problems, maybe new onset psychiatric problems, fatigue, joint pains, or muscle pains. So they look like a Lyme disease patient, but then they're given all the tests related to Lyme disease and everything comes back negative. So they're told they don't have Lyme disease. And if you're not knowledgeable that, oh, Borrelia miyamotoi is a test that you can do for people presenting with symptoms like Lyme disease, then that diagnosis is probably going to be missed. And so right when I started, I was like, wow, this is like a very important topic. We need to be checking everybody for it. We should do a research study related to it. So basically for the next couple of years, 2.5 years, we were consecutively testing everybody who came into our consultation clinic for this antibody. And we found really interesting results. We found that 26% of everybody who walked through our door, didn't matter. Basically, people could self-refer to our clinic, and they just had to be patients who had suspected tick-borne illness. And they could have had a history of
Wow.
tick-borne illness in the past, or they just had these symptoms and they thought that they had it. So it was really kind of an open-ended like referral source. And we tested everyone and we found a surprisingly high number. Like I said, 26% of everyone were positive for this antibody. Um, so I thought that was a really important public health finding. Again, most of the time, mostly because most doctors had never heard of this. Most patients have never heard about Borrelia miyamotoi. And certainly anyone living in a tick endemic area should know about this disease. And that the testing is now part of routine testing in some labs. For example, Quest Diagnostics, you can test for Borrelia miyamotoi antibody pretty easily through that lab.
So it's important for physicians to make sure that they know about that in terms of testing, unless they're going through Quest. And how about in terms of treatment?
So that's sort of a question that we're still trying to sort out.
Mhm.
The thought process, according to the CDC and other doctors, is that it's because of the fact that it's very similar to Borrelia burgdorferi. Like I said, genetically, they're They're basically like cousins. The thought process is that it's treated in a very similar fashion to Lyme disease. So that's basically how most doctors approach treating Borrelia miyamotoi, similar to how they treat Lyme disease. But what we noticed in the study is that the patients who were positive for Borrelia miyamotoi, they had a surprisingly high number of hospitalizations. It was something like, I think, 25% had been hospitalized either medically or psychiatrically prior to finding out that they had Borrelia miyamotoi disease, which is also a very high number. So there's reasons to suggest that maybe Borrelia miyamotoi actually has more neurological complications or is a more severe disease. But because we're so early on
Mhm.
in our understanding about Borrelia miyamotoi, we don't have all those details ironed out.
Wow, it's really interesting. Sounds like there's lots of research for people who want to go into this area.
Oh,
Mm.
there's amazing opportunities if people are interested in this kind of stuff, because we just don't have enough scientists and don't have enough doctors.
Yeah.
It's kind of work.
So there's other tick-borne diseases that cause similar symptoms, like babesia, for example.
Mhm.
Is that that is a parasite?
Yeah. So Lyme disease is a bacteria, which is a spirochetal bacteria. Well, let's back up for a second. Lyme disease is caused by Borrelia burgdorferi, which is the name of the bacteria, which happens to be a spirochete, which just describes like the shape of the bacteria.
Okay.
Most of the things you can get in a tick are bacteria. However, there are a few things that are parasites. So, for example, Babesia microti and Babesia duncani, two different types of Babesia infections, are parasites. They're parasites that infect red blood cells. So we often see a different symptom profile with people who have Babesia infection. They can also present with some psychiatric symptoms sometimes. They can present with fatigue because they are parasites that infect red blood cells. In a very severe case of Babesia, we can see anemia because it's affecting the red blood cell. We can also see symptoms like air hunger and shortness of breath from Babesia infection, which we don't really see related to Lyme disease.
Mm. Okay, I have written here to the side anaplasmosis. How does that fit in?
There's a bunch of different things that you can get in the tick besides Borrelia burgdorferi and Lyme disease. So I mentioned Borrelia miyamotoi before. Anaplasma, Ehrlichia, things of that nature are additional bacteria that can be transmitted through a tick. So some of them have sort of unique presentations. For example, anaplasma and ehrlichiosis, when people have it, usually those infections are not missed. And the reason they're not missed is because people present often with a really high fever, like alarmingly high fever, like 103. And so they often make it to the emergency room. And then if everybody is doing their job correctly and it's a tick endemic area, they'll look for tick-borne illness. So those patients often get really sick. However, some of these other infections like Borrelia miyamotoi, Lyme disease, Bartonella, some of them, if you have a good, robust, hardy immune system, you often don't get that fever response. Or you might just get a low-grade fever response and you're just feeling tired and you have some symptoms that may make you just think that it's a different flu-like illness, and so it can unfortunately get ignored sometimes.
Mm.
So that's one of the other important considerations, take-home points. Like if you have someone in the springtime, May is Lyme Disease Awareness Month, by the way, so this is a good time to be doing this talk. It's one of the most common prevalent months for Lyme disease. That's why it's Lyme Disease Awareness Month. But in the springtime or the summertime or even in the fall, if you have a flu-like illness that like doesn't have an otherwise related reason to be sick, for example, you don't have upper respiratory symptoms, you don't have the flu, you don't have COVID, and it's the summertime, you should definitely be thinking about Lyme disease or a tick-borne illness. especially if you're in one of these areas.
And then finally, I'll mention this one, and then I'd like to come back and talk a little bit more about this a little later. But Bartonella, which I guess is not a tick-borne, or it's unclear whether it's a tick-borne disease.
It's a little bit not entirely clear. We can find it in the ticks, but we don't see as much Bartonella in the ticks as what we see clinically in our population of patients. So it's a little bit perplexing sometimes about the tick-borne transmission related to Bartonella, and it depends on region to region. But they do sometimes find Bartonella in the ticks. So yes, it can be a tick-borne illness, but it can also be transmitted through lice, fleas, cat scratches, and probably house spiders. So there's a lot of different modes of transmission related to Bartonella.
Okay.
We're just learning, and when I say just, I mean like just in the last 5 years or so, there's been a lot of studies showing the link between Bartonella infection and neuropsychiatric disease. So it's a really important topic that is evolving like as we speak. So whereas we've known about neuropsychiatric symptoms related to Lyme disease for a few decades now, we're just beginning to understand and identify neuropsychiatric symptoms related to Bartonella infection.
Wow. And I know that you have a study that's will soon be published. It's in the preprint stage now, so I got a sneak peek at it. And I'd like to come back to that and hear about that in a little bit more detail. All right. So I hope that gives our listeners a basis for moving forward, because I'd like to start talking about what you see in your office. And can we just begin in a general sense? But let's say someone comes to your office in New York. What's your intake interview going to be like?
Yeah, I mean, the most important thing I think for any doctor, not just for me, whether they're coming in with an isolated psychiatric symptom, let's say clearly related to some like a trauma history or a PANDAS situation or a Lyme disease situation, is to just get a thorough history. So that's why I like my initial appointments are 2 hours long. I spend a lot of time with the patient just going over a lot of details about their life, childhood, depending on how old they are. Sometimes a patient is 7, but it still takes a while because these histories can be complicated. So I like to present, or I like to evaluate for kids, both the kids and the parents. I usually start out with everyone together. I like to talk to everybody individually for a period of time, just because sometimes you learn more information separately. And then I bring everybody back at the very end, and then I typically do a bunch of blood work also. And to be honest, I usually, unless someone presents to me with like a very straightforward case that seems like very much a isolated psychiatric symptom. I actually saw someone today, which doesn't usually happen for me because I usually get PANDAS referrals, but this was like a college student who developed some dissociative symptoms in the context of smoking marijuana. So like there's no reason for me to think that this is a PANDAS or Lyme disease presentation. This is more along the lines of what I would see in psychiatry during my residency. So I probably won't do a like infectious workup on them because I don't see like how that would add to things. But I probably will like talk to them about it depending on how things unfold going forward, as something we could just check so we have a better understanding of underlying like, medical history, for example. But most patients that I see, there's a strong clinical suspicion that these patients are presenting with extreme psychiatric symptoms that probably have some sort of infectious trigger by the nature of the presentation of the symptoms. And that usually means that like the parents will give a pretty clear story that like this is an abrupt personality change. This is an abrupt behavior change. This kid was not like this. And then all of a sudden they started changing. And honestly, it can look a lot of different, it can look a lot of different ways depending on sort of what age they are, depending on what underlying infection might be at play. So that's where the medical detective piece kind of comes along as well. Like, for example, about a month ago, I saw a kid, a 3-year-old actually, who presented. He was like talking totally normally, full sentences, no problems. And then in the context of a strep infection, started like significantly stuttering to the point that he like basically stopped talking because he was stuttering so significantly.
No, my.
I mean, he's 3, first of all, so that his exposure to ticks would be far more limited than for someone who's 30, for example. And these symptoms started in the context of a clear strep infection. Like, we knew that it was strep. And so I don't think I did a tick-borne illness workup, for example, in this kid. I just identified that this was a PANDAS type presentation. And based on the history, I really knew that he likely needed longer antibiotic courses of treatment, because I think he was just maybe put on 10 days and then within a week or 2 symptoms came back, type of a thing. And so that's an example of like, it was pretty clear cut history that this is PANDAS and he needs more treatment. And so I went down that road, gave him additional treatment for 3 or 4 more weeks, and his stuttering went away. So that was a success story. A lot of them are not that dramatic, successful, unfortunately, but it's very rewarding when it is. And to be honest, one of the reasons it was so successful is that he was diagnosed early on, and they realized, okay, I happened to see this kid because there was a organization, like a Jewish organization that helps patients and families. And the families reached out to the organization right away when something was wrong, and they put them in touch with the appropriate doctors. So really good things happen when patients are treated quickly and early on, because when infections and then these immune problems go on for months or years, they're definitely harder to treat.
Mm-hmm. And to diagnose, perhaps.
Yes, it just becomes a very like complicated story, especially when it looks like a PANS presentation, but no one identified it, and then gave the patient a bunch of psychiatric medications and went down the psychiatric road. Sometimes we can see psychiatric symptoms getting worse when the underlying infection isn't treated and only psychiatric meds are given. So yeah, the moral of the story is try to find the right doctor, get the diagnosis early, because the earlier you get treated, the better outcomes for sure.
Mm-hmm. So can you talk a little bit more about some of the cases that are perhaps a little bit more challenging? Is this a Lyme case? Is this a PANS case, for example? What would they present differently? What kinds of things would you home in on to distinguish the two?
For an adult who has Lyme disease, the classic presentations for an adult with Lyme disease is usually we see like 3 common symptoms, and it's typically fatigue, some degree of pain, usually joint pains, and then oftentimes cognitive problems / psychiatric, sometimes both cognitive problems and psychiatric symptoms. So that's a lot easier. That's classic Lyme disease. A 38-year-old person, otherwise healthy, lives in a tick endemic area, presents with those cardinal symptoms. That's kind of a no-brainer. Like, this looks like Lyme disease, even though they had a Lyme disease test done by their PCP, for example, and it was negative. I hear that story and I could like bet my house almost that it's Lyme disease, just because it's so classic. Where it gets a little harder and trickier is oftentimes with kids, when they present with Lyme disease, they will present only with psychiatric symptoms. So basically, they're presenting with a PANDAS picture, we see only new onset psychiatric symptoms. And usually the story is like, Ava's a second grader and she's calm and sweet and she has this great disposition her whole life and she gets along with everyone and she has a ton of friends and the teachers love her. And then all of a sudden she is having all these major behavioral problems out of the blue. And she's running out of the classroom and she's hitting her parents at home and not following rules, and then maybe refuses to go to school and has some sensory issues, like won't wear her clothes, only wears her nightgown, and is having OCD symptoms, repeating the same phrases over and over again, will only eat certain foods. So that's kind of like a typical case. So right away, it's like, okay, this is a PANS case for sure. And what do we think the trigger is? And so basically, this is a context where I would just look for all potential infectious triggers. So I would look for strep antibodies, mycoplasma, do the full tick-borne illness workup, and then go from there depending on what the labs show, basically.
Mhm. And how might the child who turns out to have Lyme disease, how might he or she have presented themselves that would be different? Or is it just that you're asking, is it just the questions that you're asking to determine whether to go down the PANS avenue or the Lyme avenue? Um, for example, asking about different illnesses that they may have had, or looking at where they live or where they've traveled recently. What helps you to distinguish between the two?
Yeah, it's not, I don't see them as two different paths, actually. They're just because we know Lyme disease can trigger these PANS symptoms. And so when they come into me with this story, I can't be certain that this, patient A looks like for sure Lyme disease versus patient B who looks like for sure strep infection triggered, for example, because they often will present with similar histories. Like if they tell me, even the patients with Lyme disease usually never saw a tick or never had a rash. So it's not as if I'm necessarily getting anything specific about the history that I'm hearing that makes me think, oh, for sure, Lyme disease. Most of the patients I see are from the Northeast. So Lyme disease is rampant everywhere in the Northeast. So that doesn't really narrow it down. If I have a kid, a 5-year-old presenting with these symptoms and they had a positive strep infection, that's probably PANS, that's probably PANDAS strep triggering all of this. But even so, I usually do the full tick-borne illness workup on everyone because it's not something you want to miss from my perspective.
Mhm.
The only thing that makes me really think Lyme disease in certain situations is, let's say they'll tell me every single summer they go to the Catskills, and they go to sleepaway camp every single summer. And then maybe they also mention that they're having pains in their knees and they're like, they can't get through the day without napping. That's definitely more Lyme disease. Or maybe they're telling me that the kid is a little bit fatigued, but also has more neurological symptoms like some dizziness, and the parents are noticing some memory problems that usually wouldn't be a typical strep presentation, but those are neurological symptoms we see a lot with Lyme disease.
Okay.
So that's when I would think Lyme disease. But if it's just like purely new onset psychiatric symptoms, either restricted eating or OCD or these like significant behavioral changes, I don't know if that's Lyme disease. Is it strep induced? Is it mycoplasma? Is it Bartonella? I don't know those things until I do the testing.
Okay. How about the onset? Are there some differences there between PANS and Lyme?
That's a good question. With Lyme disease, where it becomes tricky when we apply the sort of classic PANDAS criteria to someone who maybe has Lyme disease, is that typically we think about PANDAS as being this like very abrupt onset, new onset neuropsychiatric symptoms. We can see that in the context of Lyme disease for sure, but oftentimes it can be a little bit more smoldering of a process. So, for example, for a couple of years, they just seemed more fatigued, and then maybe they had a weird injury in their ankle or their knee, and maybe their knee became swollen. And then OCD started a year later, and then maybe they were suicidal the following year, type of a thing. So these histories are not always perfectly clear cut. And with Lyme disease, things can present in like not as dramatic of a fashion sometimes, and it can, like I said, be more smoldering. So that's a little bit harder to piece together, because it's like, oh, so they were depressed, and oh, they had the swollen knee, but no one diagnosed it as Lyme disease. And then we had OCD, and then all of a sudden, then they had ADHD and they were put on a stimulant, and then they started restricted eating. So is that the stimulant, or is this like this whole PANDAS presentation? So again, that goes to point out that like when you see these new onset psychiatric symptoms, it's so much better to get a workup earlier rather than later, because if that's diagnosed early on, potentially you can prevent all of those additional symptoms, assuming that you figure out the correct diagnosis and treatment right away.
Mhm. How much does it matter at the early stages there, whether in terms of treatment, whether it's Lyme or PANDAS PANS?
Mhm.
You would treat both with antibiotics.
Mhm.
How about steroids?
So because I'm a Lyme disease doctor, I usually don't prescribe steroids. Um, and the reason for that is because it's been kind of a long-standing wisdom or knowledge in the field that usually when it comes to tick-borne illness and Lyme disease, steroids are not good ideas to suppress the immune system if you have any active degree of infection going on. Where it gets really complicated is when you have these severe psychiatric symptoms, severe OCD that's debilitating, and severe other symptoms, and you have evidence of active infection, but then you go down the road of like even treating with IV antibiotics and multiple antibiotics, and things don't get better. So then it's like, it's very difficult to decide, like, when do you pivot? When do you go to immunomodulation like IVIG, or when do you pursue steroids? Just because in the world that I'm in, seeing a lot of patients who have Lyme and Bartonella and who have evidence of active infection, oftentimes, IVIG can be really helpful for neuropsychiatric symptoms, but sometimes it can be very activating as well. And so it's not one of these things that like everybody who gets IVIG miraculously gets better. That's not the case. In the context of these infections, sometimes symptoms actually get worse before they get better, especially if you're giving IVIG, you're activating the immune system to treat these infections. And if you don't have enough antibiotic coverage while you're activating the symptoms, that can increase neuroinflammation, increase psychiatric symptoms. So it's frequent that I will have patients who, in the course of IVIG, they can like have some hallucinations and other, like some of their psych symptoms get worse. So at that point, you have to, it's not such an easy road, because you have to like finely tailor the treatment plan depending on what's going on.
It sounds extraordinarily complicated. With every treatment that you provide, you have to watch what the effect is.
Yeah, and there's no way, like, it would be great if we could say, okay, so this patient has Lyme, and like all of this started in the context of, let's say, maybe a COVID vaccine, and then we diagnose Lyme disease. This is the appropriate treatment guidelines to do, because we know that they're going to get better. This is such like a new science that nobody understands really these complex mechanisms that are at play from either an infectious process or an autoimmune process. And so there's a lot of us just like, we're all doing our best. And then you have to be ready to pivot if something doesn't work. So there's a decent amount of trial and error going on, because they're such complicated patients and they're often very sick.
Mm. So the patient could have, and maybe I'm just making this too simplistic, but the patient who comes in could have PANS, or they could have Lyme, or they could have both, or they could have, it could be a case where the Lyme triggers the PANS.
Yeah, so basically when we think about PANS, the general working theory or consensus is that we think it's an autoimmune reaction to an infectious trigger. But I think most doctors, probably and scientists, would say that we think what's happening is there's molecular mimicry going on. So there was an infection initially, the immune system was activated to treat the infection and then developed antibodies that cross-react. Instead of targeting the infection, they're cross-reacting with parts of brain tissue and giving us symptoms. We think that's what's happening. We don't know that entirely. And to me, that doesn't perfectly describe why antibiotics are oftentimes getting people a lot better in a significant amount of PANDAS patients. I mean, it does a little bit because we know antibiotics can be anti-inflammatory. But I personally think that in PANDAS presentations, there's probably more persistent infection than we really understand. And that's mainly because we don't have good ways to test for persistent infection. Even we're just learning that with COVID too. They find evidence of the virus in a lot of different places in the body when they're able to have the tools to look for it. Same thing with Lyme disease. When they do studies, animal models, where they give animals Lyme disease, then they give them quote unquote appropriate treatment for a few weeks. Then they wait a few months and then they sacrifice the animals. They see evidence of the bacteria all over their body and at multiple different organ systems. So if that's what's happening to animals when they get appropriately treated, and now we have a huge cohort of patients who have ongoing symptoms after their Lyme infection and they got, quote, appropriately treated, why would we not think that the same thing is happening to them, that they probably have disseminated bacteria in their bodies as well? So all of those reasons, and because, like I said, clinically, I often see patients getting much better with just a little bit longer courses of antibiotics. So instead of the 10 days, being on them for about 2 or 3 months, that oftentimes then we can stop the antibiotics and things are much better. So to me, that argues potentially that there's a lot of persistent infection at play. That doesn't mean that there's not a pathological immune response there, that the persistent infection is driving an autoimmune response that's contributing to the symptoms. I think that's probably happening too. My best guess is that they're both happening at the same time. So that's my thought process. I never think, oh, this is Lyme disease. Oh, this is PANS. It's just like both processes probably happening at the same time. Both infection, directly infection related, and an autoimmune component.
Really interesting. Something that I was not aware of until recently, the Lyme disease can actually cross the blood-brain barrier. Did I understand that correctly?
So we certainly know that the bacteria can get into the brain. Yeah, 100%. That's what's likely contributing to all of these neuropsychiatric symptoms. We also know that in some cases, when someone's had chronic Lyme disease, we can do a brain MRI and we can see evidence of white matter abnormalities in the brain. That's like a classic finding that we see related to Lyme disease. So yes, the bacteria can get into the brain and cause a lot of problems, which is probably a significant reason why we see so many neuropsychiatric symptoms related to the disease. I don't think it's just that the bacteria is in the rest of our body and not our brain, and that the patients are just reacting to, psychologically reacting to things. There's a lot of evidence. We can actually find it sometimes if we do a lumbar puncture. We can find evidence of the bacteria in the brain also, which further confirms it.
So that's in contrast to PANS and PANDAS, where it's thought to be the autoantibody that crosses the blood-brain barrier and wreaks its havoc.
Yeah, my guess is, again, that a lot of these cases, it's probably both. It's the pathological antibody and it's also the bacteria, both at play.
Wow, really interesting. Wow, what a wealth of information you've provided. It's really amazing. And I think just listening to you, that listeners know that in order to do the kind of work that you do so well, that you really need to have the kind of curiosity that you're talking about and the perseverance to keep on looking for the causes and the correct treatments. Dr. Delaney, thank you.
Well, thank you for being so interested in it and doing all the extra research and reading.
I learned so much.
This concludes part 1 of episode 3. We hope you will continue listening to parts 2 and 3 of episode 3. For more information about Pandas and Pans and the Alex Manfull Fund, please visit thealexmanfullfund.org. The content in this podcast is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition.